A couple of projects that got completed. One was the human genome that gave us the option to sequence the genome. The other was what's called the HapMap. HapMap looked across the whole genome to find markers. And these markers, which we now know, are single nucleotide polymorphisms. These are markers that are scattered all over the genome, and there's about, consistently in humans, about 5 million of those markers. They isolated the first 3 million of those, gave us the option then to have markers that we could saturate the genome and use those markers to identify any genes in their close proximity that would predispose to coronary artery disease. And you see, this is the study from the VA. I point this out because our cases, even when we had 1.3 million, were about 83% of European white descent. So that we were not looking at many of your minorities. The VA study has over 600,000 people from various minorities. Our studies now, in the 2.6 million that we have, about 800 million are indeed non-European. So we now have pretty well covered the picture. And I think, as you know, 9p21 is a risk factor in all of them except Africa. Africa, 9p21 is not a risk for coronary artery disease. I can come back to explain that to you later, but that you need to know. So right now we have 300 genetic risk variants for coronary artery disease. Each of these satisfies the 10 to the minus 8, and they've all been replicated in independent populations. And so they're all on that chip from that point of view. So what we did was to pick one of the genetic variants that we know increases HDL, but it doesn't affect LDL, and it doesn't affect triglycerides. And it occurs in about 2% of the population. So by this time, we had over 500,000 in cases in controls, so we could go to this story, as you can see here. We designed it so that we'd have 90% power, and the sample size we started out with was 50,000. And what we showed here, I'll quickly just go through, is that although HDL increased significantly, there was no change in plasma LDL or in triglycerides. Despite the increased plasma HDL, as you can see here, there was no association with decreased risk or increased risk. So the first story to look at to see how accurate this would be were retrospective studies. These were studies that were done by the TEMI group, not us in the Cardioform. And they went back and looked at clinical trials and were able to recover blood on all of them to go back and do the genotyping to see what their genetic risk score would be for coronary artery disease. As you can see, at that time, there were only 27 genetic risk variants available, but that was enough to really accumulate a significant risk. And these are the 3 clinical trials that they looked at. And I'll quickly point out to you, so the genetic risk score was simply high, low, or intermediate, as you can see here. And the highest, as you can see here, when they looked at those trials that got statins, you can see in red, the high-risk group got the highest doses of statins. And so it was using the genetic risk score, it correlated with the risk that was observed in these clinical trials. And those, again, who were at the lowest risk got the least statins. As that moved along, then there are several biobanks in the world. One of them is at Oxford. Another one is in India. And this is from the Oxford group, 500,000. And what they did was to look at how good using the genetic prediction would pick up those people with heart disease versus without. It showed that the genetic risk factor was totally independent of conventional risk factors. I would say, I would put the word there relatively independent, but over and over and over again, it's about 90% independent of conventional risk factors. Secondly, the people who were in the high genetic risk score, as you can see here, the top 20% had a 1 to 4-fold increased risk of coronary artery disease. When they looked at those with known heart disease versus the high-risk group, as you can see that the correlation is just about 99%. So all of these studies indicated that using the genetic risk factor, one could detect high-risk people at risk, meaning 1 to 4-fold increased over normal. And what you're looking at here, I think, if we take the conventional risk factors and take the genetic risk factor and combine them, and using something like inclisiran, where you only have to inject once a year, I think that clearly one can look forward to the time when heart disease will be, I don't think, any more than 20th in the world rather than number 1. So combining both, I think, is truly a paradigm shift. It's probably one of the least expensive ways to go, although inclisiran is expensive at the moment, but certainly will come down with time. So I leave with you that I think it will be certainly a paradigm shift in preventing heart disease. I think the fellows in the room will still have a job, but the next group might be